All right. Well, thank you very much, Jack. And so I was going to make a poll question, but Jack gave away the answer. I was going to say, well, who is this guy? This is Joe, the drifter from The Good and the Bad, the Ugly. But this was in 1967. A lot of the audience members weren't born in 1967. So he was also Walter Kowalski in Gran Torino, and the mayor of Carmel, California, so Clint Eastwood, but a memorable one, The Good and the Bad, the Ugly. And just as a disclaimer, I'm going to show several guidelines from 3 different societies. I'm not saying which is good and which is bad and which is ugly, but I'm just sort of guidelines in general. And actually, it's more about the guidelines process and using psoriatic arthritis as kind of an illustration for that. So here are the disclosures. Anyway, as we get hooked up here and get running. So the idea of the guidelines has been something that we didn't used to have much. And you think back dozens of years ago, there were really no guidelines per se. Then they started to be developed, and they got a big push by a couple of events, and I'd kind of squished them all together here. So 1999, the Institute of Medicine released a report, To Err is Human. Basically, they were slamming doctors and saying that we had caused 44,000 iatrogenic deaths a year. And if anybody remembers back then, they said it was like a jumbo jet full of people dying every day and crashing. And they were focused on medical errors. Then there was a emphasis on quality. So again, they put out another report, 2001, Crossing the Quality Chasm, Aims for the 21st Century. And what they were talking about in the quality deficiencies is there's certainly gaps in the quality of healthcare, and there are definitely disparities. And there are things that are relatively easy to measure, like the rate of total joint replacement in a given community. Some communities are higher, some communities are lower. And as you can imagine, it's not always clear that the greater money expenditures are associated with greater outcomes. There's always been the question of the incentives, and can incentives change behavior? This was also about the start then of managed care. Now, some people would say this is not managed care, it's managed cost, that it's really not about the care, it's about trying to get as inexpensive care as possible. So with that, there became more commonly these processes that we've all had to interact with, and that is formularies and adherence to formularies and restrictions, and also utilization. And in the different modelings, there were different rewards for even not using the appropriate care. So, and some of those actually still exist, amazingly. So there are a lot of pressures to have care that is, quotation marks, optimal, which in many cases was relatively less expensive. After that, there was a big interest in quality performance indicators and proving to your payer that you were checking these boxes, that you were doing these things. And then meaningful use, or some people call it meaningless use, that you had to, again, go through certain procedures to be able to say you were performing quality medicine. And this was also the time that the electronic medical record was introduced. And the electronic medical record was the perfect venue for collecting all the information on how people were sticking to treatment algorithms or treatment guidelines. So a lot of these forces came together at the same time, and I think we see a lot of this today, although it's still a little bit in flux. But there are certainly great interest in guidelines across disciplines. In some cases, they're very well developed, very well fleshed out, very well adhered to. In conditions in like rheumatologic diseases, they're heterogeneous enough that I still think we have some pushback for that, and certainly a condition like psoriatic arthritis. So practice guidelines, again, an Institute of Medicine statement. Systematically developed statements aim to assist clinicians and patients in making decisions about appropriate health care for specific clinical circumstances. Hard to argue with that. They can also be used to guide policy and system-level decisions. That, I don't like the sound of that. That means that if the guideline is good enough, you should do this. And if you're, in fact, that's one of the things you'll see wording differences. Some societies will say guidelines, and the grade process is meant to put out guidelines. Other people back off a little bit and say recommendations. EULAR, our European colleagues, tend to make recommendations, and there's a legal difference. If you're practicing and you're not adhering to guidelines, then you're not at the standard of care, and that's by definition malpractice. So some people will soften it and not use the word guideline, but rather use the word recommendations. How were these done? And I'd like to just sort of take that history and then apply it through psoriatic arthritis and see where we are. For many of us growing up, this was the evidence-based medicine era, and we said there's a lot of literature out there. Let's look at it in a rigorous way. And we all are familiar with these. What do you do if you want to have a systematic review that's going to generate recommendations? Well, you go through all these processes. You do a thorough literature search. You review the literature. You assess it for the strength of the literature. You end up with these assessments that the highest source would be from meta-analyses of randomized controlled trials. That would be level 1A evidence. 1B would be several randomized controlled trials, all the way down to level 4, which would be expert committee opinions and clinical experience. And that then, depending on the strength of the evidence from which you're able to ascertain from the literature, would allow you to make recommendations that were A, B, C, or D. So these are things that we had become familiar with. And when we first did the GRAPPA, this is the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, a group of international rheumatologists and dermatologists, we followed that process. And these are the guidelines that we came up with then. And you can see how old these are, because there's so many things that are not on there. Biologics is TNF back in the day. And yet we use that old process to come up with these. And there was certainly good evidence or reasonable evidence for many of these interventions. We also at that time came up in psoriatic arthritis to say, well, there's differences across different domains. So we came up with a structure where you would, in a way, dissect psoriatic arthritis into the relevant domains and then pick the therapies that fit with that. So in those days, you could say, well, how did you know your guideline or your recommendation was good? Well, there's the AGREE instrument, and there's a lot of people sitting around thinking about how best to make guidelines. And some people came up with these. A lot of these are Canadian investigators. And they're just the kind of general, I mean, they all seem good. The scope and the purpose, the relevant stakeholders should be involved. It should be a rigorous process. It should be clear. It should be applicable to the clinical situation, and from an ethical standpoint, there should be editorial independence. So these were all very reasonable points that still actually hold true for any set of guidelines that you might see. But this has kind of evolved. The old guidelines, I call them bog set guidelines. A bunch of guys sitting around a table and said, yeah, here's an article on methotrexate. Oh, yeah, that works in the skin. Okay, check that box. And, then go back and fill the AGREE instrument out afterwards to say, yeah, we checked those boxes. And you know what? They're still being used in this way, particularly for areas about which there's really very, very little evidence. And I put a couple of them up here. These generate clinical care pathways. They're not saying that they're recommendation. They're just sort of saying this is an approach. This is the treatment of IBD in pregnancy critical care pathway from 2019, and also the clinical practice guideline for the management of osteoporosis, also in 2019. This is kind of the same older way of literature review and evidence grading and recommendation creating that we had since the 90s. This is still being used. There are different ways that people will talk about this. This is the SORT process, strength of recommendation taxonomy. So as you see, this kind of looks familiar to the same processes that we'd had in the past, that we look for the evidence, good quality, patient-oriented evidence, all the way down to other evidence, including opinion and case studies, and giving you recommendations that then can be graded A, B, or C. And these were used by the National Psoriasis Foundation in the American Academy of Dermatology, NPF, guidelines for the treatment of psoriasis. Now, they had multiple iterations of this in different populations, but here you see what you have for practical clinical scenarios and the strength of recommendation. So the more common, the more the things that have been studied, gets a higher level of a recommendation. So these kind of guidelines are still in existence. And there's another aspect of those that generated about 5 or 6 publications from the AAD NPF PSO guidelines, and here you see them here, including what should you do with comorbidities. And they have sort of a clinical practice pathway, if you see, based on some evidence about what you would do in the presence of particularly comorbidities that would increase the risk of MACE and how you would treat those. And these are actually pretty reasonable, it seems, a bit aspirational, I think, for many of our dermatology colleagues who don't often get into the weeds about the comorbidities, such as risk for MACE events. But these have largely been supplanted by a process called GRADE. And here you see one of the original articles from this. This is from Gordon Guyette, also from McMaster. As I said, a lot of the people who had been in the evidence-based medicine field for decades were Canadian investigators. So what is GRADE, and how did it all of a sudden become the absolute standard? Well, here's kind of the process for generating guidelines as you see here. So you take the literature reviews, similar to how you had done in the past. You grade them. The essential element of this, though, is the creation of the PICO, the population, the intervention, the comparator, and the outcome. So the grade recommendations actually work fantastic in a very simple clinical situation, at least to my assessment. So if you have a hypertensive patient who also has diabetes, which is a better drug, an ACE inhibitor or a beta blocker? Well, you get all the studies and you do a pairwise comparison and you say, well, the population is as we defined it, these are the 2 interventions, these are the comparators that you have, and what outcomes we would look at, blood pressure control or other sequelae such as outcomes like MACE outcomes. So you set up the PICO questions, which then is of course central to the whole process of GRADE. Then you get the literature, rate the literature, take exogenous factors into account. What you end up with, GRADE, is recommendations, either recommendations for or recommendations against. And those can be either conditional or strong recommendations, again, based on the evidence. Overnight, these really became absolutely standard. That you see that the ACP, for example, American College of Physicians, has gone full bore with these. That this is the GRADE process is the way to the optimal way to make recommendations. A difficulty comes with heterogeneous diseases, and also in which there's a paucity of really good evidence across many clinical questions, and that certainly fits with psoriatic arthritis. With psoriatic arthritis, you can't boil it down to 2x2 tables, because you would have literally thousands of 2x2 tables for the numerous therapies we have available to us now across the different domains of disease, with consideration of some differences in the background of the affected patient. So it's a bit challenging to try to do that. So let me show you a couple of examples where this has been tried. Before I get that, actually, here's my poll question. Which of the following describes how you mostly use treatment practice guidelines in your practice? A, I follow them closely and use them to help me decide what treatments. B, I'm aware of them. I use them to remind myself of possible treatment options. C, I use them to support a decision I already made, e.g. for the insurance company. Or D, guidelines, I don't need no stinking guidelines. So go ahead and vote, and let's see what we have here. I'm aware of them and use them to make myself knowledgeable about potential treatment options. Okay, interesting. Nobody said I don't use treatment guidelines, at least as of yet. Follow them closely. It was like a horse race. I like this. Coming into the lead is follow closely. But use them to support treatment decisions that I already made. So I think there's different ways to do this. And of course, I think these could all be a possible answer depending on the clinical scenario. The more evidence there is, the more you could say, well, the guidelines then are taking that evidence, and it makes reasonable sense that you would use that to actually support your treatment decisions. So what about the guidelines that as we've had, and what about what's going on in psoriatic arthritis? So I showed you the very early GRAPPA guidelines, which are very much based on sort of the older method, the old RAND UCLE method of grading the literature. In 2015, we redid these, kind of tried to come up with more of a grade-ish sort of approach. But a difficulty is it's really quite hard to do that because you can't say your treatment choice is not always drug A versus drug B. There's A, B, C, D, and E. That's simplified somewhat by the approach to domains where we've already sort of gone through, and you can make a case for not using certain options. For example, for axial disease, you could say that there's not at present evidence for IL-12/23, which here it was up in the air. This is back a few years, or IL-23 inhibitor, but there was data for TNF and for IL-17. These are the older ones, and these are still mostly old-timey, although sort of grade-ish. And you can see, my gosh, how out of date they are because of all the things that we're missing. So I'll show you the updated version, at least a draft of the updated version coming up. So these were sort of grade light, if you will, in how they were done. The ACR, along with the NPF, did guidelines, and they used the grade process. They went full in for the grade process. And what that does is it puts a lot of things sort of head to head, or at least they tried to follow the grade recommendations. Interestingly, there's almost nothing that was a strong recommendation. Almost everything was a conditional recommendation except to not smoke. And I think they sort of made that up because there's no data that really suggests that if you're a smoker and you stop, it's going to result in clinical changes. But be it as it may, that was a strong recommendation. Everything else was fuzzy, but they did follow the grades outline and stuck to it very closely. So they ended up with several sorts of clinical scenarios. They defined the population and said that this would be patients with severe psoriatic arthritis based on these, which are reasonable, but of course nothing can be purely grade because severe is in the eye of the beholder. These make absolutely complete sense. These are very reasonable, but these are not based strictly on evidence saying that this is more severe than that. But these are, I think the idea was that these are the patients for whom we want the most support where we're trying to make clinical decisions. And they have, and I think you have seen these, that last was the actual, the publication, but just making it a little bit more clear because it's just got sort of overwhelming. Recommendations for treatment-naive active psoriatic arthritis. So one of the things that, in their estimation, looking at the literature, they came up with starting a TNF biologic over what they call OSM, which it's a neologism of oral small molecule, meaning methotrexate. So that in their estimation, you would start a TNF over an oral small molecule. You would start an oral small molecule over IL-17 inhibitor or a 12/23 inhibitor. You would start methotrexate over nonsteroidals, and you start an IL-17 over a 12/23. So these are things that they came by pairwise comparison of the two different classes, and that's kind of how the grade process does. Interestingly, now this has been sort of reconsidered, particularly in light of the SEAM PsA study, which showed, although it didn't have the sleep placebo group just really generated an effect size, it showed that methotrexate wasn't so bad. It seemed to work closely to the TNF inhibitor, in this case etanercept, in that study. So these have been have to be rethought. And here's just the next level: active despite oral small molecule, switch to a TNF over another molecule, as you can see. You can read these, and I think you have read them. There's some issues, I think, sticking closely to the grade process. This is kind of the blow-up view of the EULAR 2019 algorithm for the treatment of PsA. So they really stuck with the old school process of, we're just going to look at the literature, we're going to make a decision about what is good literature or not, we're going to create it. Here what they did is to sort of break out skin completely. Skin is, if it's severe, consider a referral to a dermatologist. Different than we took in the GRAPPA recommendations for sure, but they really like, in the EULAR guidelines, they like it to be in an algorithmic fashion. Not unreasonable as they go through. They do go to methotrexate first, and they're very dependent on cost as a exogenous factor. So, for example, apremilast is very, very late in their recommendations, based almost entirely on cost, not its efficacy, not its safety and tolerability. So these are the EULAR recommendations, and they go into just kind of different phases. The more drugs you fail, the later in the phase that you go. And this is another way of looking at that. As you see for arthritis, they say conventional synthetic DMARD, preferably methotrexate. Oligoarthritis they raise, and it's interesting, it's an important issue, very rarely addressed in clinical studies. Most clinical studies, you have to have 3 or more joints to get in, and most of the people have much more than that. So you're really dealing with polyarticular disease. Enthesitis and axial disease, they don't single out dactylitis specifically. No indication for conventional synthetic DMARDs, which I don't think would fit necessarily with the data that we have. It's a tricky area because in psoriatic arthritis studies, peripheral arthritis is almost always the main outcome. So enthesitis, dactylitis, skin, those are secondary outcomes. And it's when the study's not based on that, it gets you into some tricky issues sometimes. Then the biologics, then the JAK inhibitors, then apremilast, way down the line, and for mild disease, which doesn't necessarily seem incredibly logical, but I think a lot of issues based on cost for that. And then the GRAPPA recommendations. These are just being redone. They just have been redone. They've been submitted, and the paper is in revision. Should be hopefully published relatively soon. What was different from the last time, in addition to the 6 domains that we had, so skin, nails, enthesitis, dactylitis, peripheral arthritis, and axial arthritis, we also added related features, iritis and uveitis. And also had comorbidities as a separate area of interest, if you will, for elaboration and for study. So each domain group plus those other 2 groups generated PICO questions. The systematic literature review was done, data was extracted, the evidence was rated, and here you see grade kinds of recommendations: strong, for, conditional against, and strong against, and also a category we threw in where there's no recommendation. And we left this for area, instead of saying conditional against if there was no data, this was for, there are some choices that some people think could work based on their experience, other people say there's no data, so we left that as a gray area and left it gray. And this is now this is a draft. The final version is going to be different. There are a couple of mistakes on here, so I would not put much attention to this, but you just see sort of how it flows, the peripheral disease, the choices that you have, axial, enthesitis, dactylitis, skin psoriasis, and skin or nail psoriasis, but also now IBD and uveitis. We do the same process with the comorbidities, and that is that they're sort of a filter, that you take the choices. So which domain is most important to the patient, just like we do in the clinic. What bothers the patient most, then that's where you're going to look first and say, here's the choice of therapies. What else do they have that is of impact to them? What are the therapies for that? Then you get to the comorbidities and say, well, what is if the patient has this comorbidity, what is that going to do? So, and that's how we kind of end up. So, guidelines, I think, I don't like them, as you see. I wrote cranky editorials about them because I think that's partly why we became rheumatologists, isn't it? Because we don't like people telling us what to do. We like to think of things on our own and use the same things we've always done with the patient to pick the optimal therapy. So with that, let me stop and thank you all for listening. And maybe I have a question or two, Jack?
So do you think there'll be a time when we'll be able to use 2 biologics in a treatment with PsA, and you think guidelines will ever address that?
Great question, very important issue. I think many people have probably heard there was a very nice study in ulcerative colitis called VEGA that just read out. They just presented the results at ECHO, the European Crohn's and Colitis Organization meeting. Golimumab, guselkumab, or the combination, and it was a positive study. The combination did better in all the clinical outcomes and was not disadvantageous from a safety standpoint. So the bugaboo in rheumatology has been that the combination therapies, well, they didn't work, but they did have a signal in terms of more infections. This one did not. So I think combination therapy is definitely coming. There's an ongoing study with the same combinations in psoriatic arthritis, and I'm sure there'll be more.
Why haven't the guidelines addressed things like diet, fish oil, and things like that?
That's, it's interesting because that's important and it's been raised, but you think of the difficulty getting good studies of a drug and you say methotrexate, well, what dose of methotrexate, et cetera. You think of diet, the permutations are infinite. And so if you could keep humans in a cage and feed 100 of them the Mediterranean diet and let the other eat In-N-Out burgers, in a controlled setting, you would get some data from that, but you can't. And so things that are so variable like that lend themselves poorly to study, so we don't have great data.
So 2 questions about TNF inhibitors. How long do you wait before you go to a TNF inhibitor? And can you skip methotrexate and go right to a TNF inhibitor?
Yeah, unfortunately, in the U.S., I think that's driven by the payers in a lot of situations. And we still have people that have to be on a TNF inhibitor before they can get on methotrexate before they can get a TNF inhibitor approved, even if their disease would be something that I would say, you know what, I know they're going to end up on a TNF inhibitor, but still we have to go through methotrexate sometimes.
All right, superb. All right, thank you, Artie. That was great.